Chapter 58 Antiviral Drugs. Viruses are the ultimate expression of parasitism. They not only take nutrition from the host cell but also direct its metabolic machinery to synthesize new virus particles. Viral chemotherapy, therefore, was considered impossible, as it would require interference with cellular metabolism in the host. However, in the past 50 years, virus-directed enzymes have been identified in the infected cell, and some viruses have few enzymes of their own which may have higher affinities for some antimetabolites or inhibitors than the regular cellular enzymes. In addition, drugs have been developed which target virus-specific steps like cell penetration, uncoating, reverse transcription, virus assembly or maturation, etc. Another stumbling block is that in majority of acute infections, viral replication is already at its peak when symptoms appear. To be effective, therefore, therapy has to be started in the incubation period, i.e. has to be prophylactic or preemptive. Classification 1. Antiherpes virus idoxuridine, trifluridine, acyclovir, valacyclovir, famciclovir, ganciclovir, valganciclovir, cidofovir, foscarnet, fomiversin. 2. Anti-influenza virus amantadine, rimantadine, oseltamivir, janmivir. 3. Anti-hepatitis virus non-selective antiviral drugs primarily for hepatitis B, lamivudine, hadifovir dipivoxil, tenofovir primarily for hepatitis C, ribavirin, interferon alpha 4. Antiretrovirus A, nucleoside reverse transcriptase inhibitors, NRTIs zidovudine, AZT. Didenosine, stavudine, lamivudine, abacavir, entricitabine, tenofovir, anti-RTI, B, non-nucleoside reverse transcriptase inhibitors, NNRTIs nevirapine, efavirenz, dilaverdine, C, protease inhibitors, ritonavir, adjanvir, indinavir, nelfinavir, saquinavir, ampranavir, lopinavir, D, entry, fusion inhibitor, enfuvirtide, E, CCR5 receptor inhibitor, maraviroc, F, integrase inhibitor, raltegravir. Anti-herpes virus drugs. These are drugs active against the herpes group of DNA viruses which include herpes simplex virus 1, HSV 1, herpes simplex virus 2, HSV2, varicella zoster virus, VZV, Epstein-Barr virus, EBV, and cytomegalovirus, CMV. Idoxuridine, it is 5-iodo-2-deoxyuridine, IUDR, which acts as a thymidine analog. It was the first pyrimidine antimetabolite to be used as antiviral drug. It competes with thymidine, gets incorporated in DNA so that faulty DNA is formed which breaks down easily. It is effective only against DNA viruses, and clinical utility is limited to topical treatment of herpes simplex keratitis. Because of low virus selectivity, higher local toxicity, and rapid development of viral resistance, use of idoxuridine is restricted to superficial dendritic keratitis when rapid action is required. Idoxuridine eye drops act faster than acyclovir eye ointment, which is more effective when there is stromal involvement of the cornea. Ocular irritation occurs with idoxuridine eye drops. Dose 0.1% eye drops to be instilled hourly, then 2 hourly and 4 hourly. Apply 0.1% eye ointment at night. Idurine, Toxil 0.1% eye drops and eye oint. Trifluridine, it is a fluorinated nucleoside which acts in the same way as idoxuridine and inhibits HSV1, HSV2, CMV and related viruses. However, virus selectivity is low and DNA synthesis in host cells is also affected. In India, trifluridine eye drop is approved for use in H. simplex keratitis. Higher efficacy than idoxuridine eye drops is reported. Ocular irritation and lid edema can occur. 799. Chapter 58. Antiviral drugs. Acyclovir. This deoxyguanosine analog antiviral drug requires a virus-specific enzyme for conversion to the active metabolite that inhibits DNA synthesis and viral replication. Acyclovir herpes virus-specific thymidine kinase acyclovir monophosphate cellular kinases inhibits herpes virus DNA polymerase competitively. Acyclovir triphosphate gets incorporated in viral DNA and stops lengthening of DNA strand. The terminated DNA inhibits DNA polymerase irreversibly. Acyclovir is preferentially taken up by the virus-infected cells. Because of selective generation of the active inhibitor in the virus-infected cell and its greater inhibitory effect on viral DNA synthesis, acyclovir has low toxicity for host cells. A several hundred-fold chemotherapeutic index has been noted. Acyclovir is active only against herpes group of viruses. HSV 1 is most sensitive, followed by HSV 2. VZV is equal to EBV, while CMV is practically not affected. HSV and VZV have been found to develop resistance to acyclovir during therapy, the former primarily due to mutants deficient in thymidine kinase activity and the latter primarily by change in specificity of virus-directed enzyme so that its affinity for acyclovir is decreased. Pharmacokinetics. Only about 20% of an oral dose of acyclovir is absorbed. It is little plasma protein bound and is widely distributed, attaining CSF concentration that is 50% of plasma concentration. After topical application, it penetrates cornea well. Acyclovir is primarily excreted unchanged in urine, both by glomerular filtration and tubular secretion. Plasma T-half is 2 to 3 hours. Renal impairment necessitates dose reduction. Zovirax 200 mg tab, 250 mg per vial for IV inch. Cyclovir 200 mg tab, 5% skin cream. HERPX 200 mg tab, 3% eye oint, 5%. Skin cream. Ocuvir 200, 400, 800 mg tab, 3% eye oint. Acivir DT 200, 400, 800 mg tab. Acivir I 3% oint. Use. Acyclovir is effective in patients with normal as well as deficient immune status. 1. Genital herpes simplex, generally caused by type 2 virus, can be treated by topical, oral or parenteral acyclovir depending on stage and severity of disease. Primary disease. Topical treatment has low efficacy. 5% ointment is applied locally 6 times a day for 10 days. This is useful only if started early and in mild cases. Late and more severe cases should receive oral therapy, 1 g day in 5 divided doses or 400 mg TDS for 10 days, in addition to local therapy. Both local and oral therapies afford symptomatic relief and rapid healing of lesions, but do not prevent recurrences. Recurrent disease. Topical therapy is totally ineffective. Response to oral treatment is slow and incomplete. Severe cases may be treated parenterally, 5 mg per kilogram IV infused over 1 hour, repeated 8 hourly for 10 days. Suppressive oral therapy with 400 mg BD has been shown to prevent recurrences as long as given. It is recommended to stop treatment after 1 year and ascertain whether the patient is still having recurrences. If so, restart treatment. After prolonged therapy, frequency of recurrences is reduced. Continuous acyclovir prophylaxis is generally advocated in patients with 8 recurrences per year. However, suppressive therapy reduces but does not totally prevent disease transmission to sexual partner. 2. Mucocutaneous H. simplex. It is a type 1 virus disease, remains localized to lips and gums, does not usually require specific treatment, but acyclovir skin cream may provide some relief. Spreading lesions may be treated with 10-day oral acyclovir. Prophylactic oral therapy may prevent sun exposure-related recurrences. The disease often gets disseminated in immunocompromised individuals and may be treated with oral or IV acyclovir, 15 mg/kg day, for 7 days, but recurrences are not prevented. 800. Section 12. Antimicrobial drugs. 3. H. simplex encephalitis, type 1 virus acyclovir 10 to 20 mg/kg 8 HR IV for 10 days is the drug of choice. Treatment is effective only if started early. Delay precludes salutary effect on mortality and neurological complications. 4. H. simplex, type I, keratitis. Acyclovir is equally effective as idoxuridine in superficial dendritic corneal ulcer and may be better for deep stromal infections because of good corneal penetration. Though acyclovir eye ointment acts slower than idoxuridine eye drops, blindness can be prevented. The eye ointment should be applied 5 times daily till 3 days after healing. 5. Herpes zoster. The varicella zoster virus is less susceptible to acyclovir. As such, higher doses are needed and it should be used only in immunodeficient individuals or in severe cases, 10 mg/kg 8 HR IV for 7 days. Oral therapy with 800 mg 5 times daily is beneficial only if started early. It affords symptomatic relief and faster healing of lesions. Postherpetic neuralgia is not prevented, though its duration may be shortened. Acyclovir skin cream may be applied on herpetic ulcers. 6. Chickenpox. In patients with immunodeficiency and in neonates only calls for specific therapy. Acyclovir, 15 mg/kg day IV times 7 days, is the drug of choice, reduces fever, eruptions, hastens healing and prevents visceral complications. Oral acyclovir 400 mg 4 times a day for 7 days given during the incubation period may abort chickenpox in susceptible contacts. Adverse effects: topical, stinging and burning sensation after each application. Oral, the drug is well tolerated, headache, nausea, malaise and some CNS effects are reported. Intravenous, rashes, sweating, emesis and fall in BP occur only in few patients. Dose-dependent decrease in GFR is the most important toxicity, occurs especially in those with kidney disease, normalizes on discontinuation of the drug. Reversible neurological manifestations, tremors, lethargy, disorientation, hallucinations, convulsions and coma have been ascribed to higher doses. No teratogenic potential has been noted. Valacyclovir. It is an ester prodrug of acyclovir with improved oral bioavailability, 55–70%, due to active transport by peptide transporters in the intestine. During passage through intestine and liver, it is completely converted to acyclovir in the first passage by esterases. Thus, higher plasma levels of acyclovir are obtained, improving clinical efficacy in certain conditions, e.g. it is the drug of choice in herpes zoster. Valacyclovir is excreted in urine as acyclovir with 80 half of 3 hours. Dose: for genital herpes simplex, first episode 0.5 to 1.0 GBD times 10 days, recurrent episode 0.5 GBD times 3 days, suppressive treatment 0.5 GOD times 6 to 12 months. For orolabial herpes 2 GBD times 1 day. In immunocompromised patient 1 GBD times 5 days. For herpes zoster 1 G TDS times 7 days. Valsivir 0.5 G, 1.0 G tabs. Famciclovir. It is an ester prodrug of a guanine nucleoside analog penciclovir, which has good oral bioavailability and prolonged intracellular T-half of the active triphosphate metabolite. Like acyclovir, it needs viral thymidine kinase for generation of the active DNA polymerase inhibitor. Famciclovir inhibits H. simplex H. zoster but not acyclovir-resistant strains. Some activity against hepatitis B virus, HBV, has been noted. It is used as an alternative to acyclovir for genital or orolabial herpes and herpes zoster. Early treatment of herpes zoster reduces the duration of post-herpetic neuralgia but not its incidence. Dose: genital herpes, first episode, 250 mg TDS times 5 days, recurrent cases 250 mg BD for up to 1 year. Herpes zoster and orolabial herpes 500 mg TDS for 7 to 10 days. Famtrix 250, 500 mg tabs. Famciclovir is a less active alternative to lamivudine in chronic hepatitis B, but not in resistant cases. Side effects are headache, nausea, loose motions, itching, rashes and mental confusion. Penciclovir, the active metabolite of famciclovir, is available for IV use in some countries. 801. Chapter 58. Antiviral drugs. Ganciclovir. It is an analog of acyclovir, which is active against all herpes viruses including H. simplex, H. zoster, EBV and CMV, against which it is most active. Ganciclovir is also activated intracellularly by virus-specific thymidine kinase, and its triphosphate nucleotide preferentially inhibits viral DNA polymerase. This active metabolite attains much higher concentration inside CMV-infected cells. The precursor cells in bone marrow are also quite sensitive to ganciclovir, and this may account for its bone marrow toxicity. Due to poor oral absorption, bioavailability of ganciclovir is low, less than 10%. Valganciclovir, the Valil prodrug, has tilde 8 times higher bioavailability and is preferred where available. Ganciclovir and its active metabolite are mostly excreted unchanged in urine. The plasma T-half of ganciclovir is 2 to 4 HRS, but that of its triphosphate inside CMV-infected cells is greater than 24 hours. These factors account for its high activity against CMV infections. CMV can develop ganciclovir resistance by mutation of viral phosphokinase and or viral DNA polymerase. Systemic toxicity of ganciclovir is high: bone marrow depression, rash, fever, vomiting, neuropsychiatric disturbances. Therefore, use is restricted to prophylaxis and treatment of severe CMV infections, pneumonia, colitis, retinitis, in immunocompromised, AIDS, transplant recipient patients. Treatment may be initiated with IV infusion of ganciclovir 10 mg/kg day, which can prevent blindness in AIDS patients with CMV retinitis. Oral valganciclovir has replaced IV ganciclovir for long-term therapy. After control of tabs. Cidofovir. It is a monophosphate nucleotide analog of cytidine, which inhibits most DNA viruses including HSV, CMV, pox and adenoviruses. Many HSV resistant to acyclovir and many CMV resistant to ganciclovir are susceptible. Because it is a monophosphate, it does not require viral phosphokinase, and is converted to the active diphosphate by cellular enzymes. Cidofovir diphosphate does not preferentially accumulate in virus-infected cells, but remains intracellularly for long periods to inhibit viral DNA polymerase, as well as acts as its alternative substrate. Weekly therapy is, therefore, possible despite short plasma T-half, 2 to 3 hours, of cidofovir itself. CMV develops cidofovir resistance by mutation of its DNA polymerase. Very little cidofovir is absorbed orally. It is administered by infusion with pre- and post-dose oral probenecid, which inhibits its tubular secretion and improves its availability for entering into cells, as well as reduces nephrotoxicity. Cidofovir 5 mg per kilogram IV weekly, and then every 15 dias is used for CMV. Retinitis in AIDS patients, particularly those who have failed ganciclovir therapy. It can also be used for acyclovir-resistant mucocutaneous herpes simplex in immunosuppressed patients. It can be applied topically on anogenital warts. The primary toxicity of cidofovir is dose-related kidney damage. Gastric disturbances, constitutional symptoms, hypersensitivity reactions, neutropenia and uveitis are the other adverse effects. Foscarnet. It is a simple straight-chain phosphonate unrelated to any nucleic acid precursor which inhibits viral DNA polymerase and reverse transcriptase. It is active against H. simplex, including strains resistant to acyclovir, CMV, including ganciclovir-resistant ones, other herpes group viruses and HIV. Viral resistance to foscarnet is minimal. However, viral selectivity of foscarnet is low. Oral absorption is poor. Its T-half is 4 to 8 hours, and it is not metabolized. Toxicity of foscarnet is high, damages kidney, produces a renal diabetes-like condition, acute renal failure can also occur. Anemia, phlebitis, tremor, convulsions, and other neurological as well as constitutional symptoms due to hypocalcemia are frequent. Administered by IV infusion, foscarnet has been used for 1. CMV retinitis and other CMV infections in AIDS patients. Efficacy is similar to ganciclovir, includes resistant cases, but produces more adverse effects. 2. Acyclovir-resistant mucocutaneous H. simplex type 2 and varicella-zoster infections in AIDS patients. When used to treat associated CMV H. simplex VZV infection in AIDS patient, it decreases HIV viral titer and may improve outcome in patients receiving highly active antiretroviral therapy, HART. Fomiversin. It is an antisense oligonucleotide which binds to the mRNA of CMV and interferes with transcription of early peptides in viral replication. CMV that has become resistant to ganciclovir, cidofovir and foscarnet is inhibited by fomiversin. For CMV retinitis, it has been injected weekly to monthly into the vitreous humor. Ocular complications are common, and it has been discontinued in USA. Anti-influenza virus drugs. Amantadine. Chemically, it is a unique tricyclic amine. Unrelated to any nucleic acid precursor, but inhibits replication of influenza A virus, A. Myxovirus. The antiviral activity of amantadine is strain-specific, influenza B is not affected. Moreover, H5N1, avian influenza bird flu, and H1N1, swine flu, strains of influenza A are resistant in most areas. It appears to act at an early step, possibly uncoating, as well as at a late step, viral assembly, in viral replication. A protein designated M2 which acts as an ion channel has been identified as one of its targets of action. Resistance to amantadine develops by mutation causing amino acid substitutions in the M2 protein. Amantadine is well absorbed orally and excreted unchanged in urine over 2 to 3 days. T-half 16 hours. 802. Section 12. Antimicrobial drugs. Adverse effects generally well tolerated, nausea, anorexia, insomnia, dizziness, nightmares, lack of mental concentration, rarely hallucinations have been reported. Ankle edema occurs due to local vasoconstriction. Uses 1. Prophylaxis of influenza A2 during an epidemic or seasonal influenza, especially in high-risk patients. Influenza season and epidemics generally last till 2 months, and only this period needs to be covered by prophylaxis. Only when the epidemic-causing strain of virus is known to be sensitive to amantadine should prophylactic use be considered. For seasonal prophylaxis, success rate is variable, but often substantial. Amantadine does not interfere with antibody response to influenza vaccination. Both may be given together. If the vaccine is given, amantadine can be stopped after 2 weeks. However, amantadine is no longer recommended in UK either for prophylaxis or for treatment of influenza. 2. Treatment of influenza A2 illness, a modest therapeutic effect, reduction in fever, congestion, cough and quicker recovery occurs if the drug is given immediately after the symptoms appear. A 5-day treatment is advised. 3. Parkinsonism, CCH 31. Dose 100 mg BD, elderly, half dose, children 5 mg/kg day. 100 mg OD may be used for prophylaxis. Amantral, Niemann 100 mg tab. Contraindications, epilepsy and other CNS disease, gastric ulcer, pregnancy. Rimantadine, this methyl derivative of amantadine, is more potent, longer acting, T-half 30 hours, and better tolerated than the parent drug. Incidence of side effects is lower. Oral bioavailability of rimantadine is higher and it is largely metabolized by hydroxylation followed by glucuronide conjugation. The metabolites are excreted in urine. Dose and clinical application in influenza A is similar to amantadine and it is being preferred over the latter. However, amantadine-resistant virus is resistant to rimantadine as well. Dose 100 mg BD, elderly and renal insufficiency patients 100 OD, children 5 mg/kg day. Flumidine 100 mg tab. Oseltamivir, this newer anti-influenza virus drug, is a sialic acid analog with broad-spectrum activity covering influenza A, amantadine sensitive as well as resistant, H5N1, bird flu, NH1N1, swine flu, strains and influenza B. It is an ester prodrug that is rapidly and nearly completely hydrolyzed during absorption in intestine and by liver to the active form oseltamivir carboxylate with an oral bioavailability of ~80%. The active metabolite is not further metabolized and is excreted by the kidney with a T-half of 6 to 10 hours. It acts by inhibiting influenza virus neuraminidase enzyme, which is needed for release of progeny variants from the infected cell. Spread of the virus in the body is thus checked. Resistance can develop by mutation of the viral neuraminidase enzyme. In many areas, oseltamivir-resistant H1N1, seasonal influenza, and H5N1 have been encountered, though swine flu, NH1N1, is still mostly sensitive. Some oseltamivir resistant strains remain susceptible to Janmivir and vice versa. Oseltamivir is indicated both for prophylaxis as well as treatment of influenza A, swine flu, bird flu and influenza B. Started at the onset of symptoms, it is the most effective drug, reduces the severity, duration and complications of the illness. Prophylactic use for 5 to 10 days prevents illness in contacts of influenza patients. Dose: therapeutic 75 mg oral BD for 5 days, prophylactic 75 mg OD. Tamiflu, antiflu 75 mg cap, 12 mg per milliliter susp, Fluvier 75 mg cap. Side effects are nausea and abdominal pain due to gastric irritation, reduced by taking the drug with food, headache, weakness, sadness, diarrhea, cough and insomnia. Skin reactions have been reported. Janmivir, another influenza A, including amantadine-resistant, NH1N1, H5N1 strains, and influenza B virus neuraminidase inhibitor that is administered by inhalation as a powder due to very low oral bioavailability. Small amount. 803. Chapter 58. Antiviral drugs. That is absorbed after inhalation is excreted by the kidney with 80 of 2 to 5 hours. The mechanism of action, clinical utility and efficacy of Janmivir are similar to that of oseltamivir. Some variant strains resistant to oseltamivir remain sensitive to Janmivir and vice versa. It can be used as an alternative to oseltamivir and is equally effective in reducing severity, duration and complications of the disease. Prophylactic use may be made for 7 to 10 days in household contacts. Dose: 10 mg through breath-actuated inhaler, BD times 5 days for treatment and OD for prophylaxis. Relenza 5 mg per actuation powder inhaler. The inhaled powder can induce bronchospasm in some individuals. This may be severe in asthmatics, contraindicated in them. Headache, dizziness, nausea and rashes are mild and infrequent side effects. Anti-hepatitis virus non-selective antiviral drugs. Several antiviral drugs are relatively virus non-selective and inhibit viruses belonging to different classes, even cover both DNA and RNA viruses. While hepatitis B virus, HBV, is a DNA virus which, like retroviruses, can integrate into host chromosomal DNA to establish permanent infection, the hepatitis C virus, HCV, is a RNA virus which does not integrate into chromosomal DNA, does not establish non-curable infection, but frequently causes chronic hepatitis. Lamivudine, a nucleoside analog, is active against HBV as well as HIV and is described with antiretroviral drugs on P80708. Adifovir dipivoxyl adifovir is a monophosphate analog of AMP which is active against HBV and some other DNA as well as RNA viruses, but is used only for hepatitis caused by HBV. Esterases in the intestine and liver release the active drug during absorption to attain oral bioavailability of till 60% in terms of adifovir, which is then distributed in whole body water. On entering cells, adifovir is phosphorylated to the diphosphate which has high affinity for HBV. DNA polymerase compared to host cell DNA polymerase. This enzyme is inhibited and adifovir itself gets incorporated in the viral DNA resulting in termination of the DNA chain. Adifovir is primarily excreted by the kidney. While its plasma T-half is 7 hours, intracellular T-half of the diphosphate is up to 18 hours. Adifovir is indicated in chronic hepatitis B, including lamivudine-resistant cases and those having concurrent HIV infection. There is no cross-resistance between adifovir and lamivudine. Clinical, biochemical, liver function tests, histological, serological and virological response occurs in nearly 50% patients within 1 year. More cases respond with continued treatment. The optimum duration of treatment is uncertain. Occurrence of adifovir resistance is infrequent. Dose 10 mg per day, Adesra, adifovir 10 mg tab. At 10 mg per day dose, adifovir is well tolerated. Side effects are sore throat, headache, weakness, abdominal pain and flu syndrome. Nephrotoxicity occurs at higher doses and in those with pre-existing renal insufficiency. Lactic acidosis is a risk in patients receiving anti-HIV drugs. Tenofovir, it is a monophosphate nucleotide related to AMP, which is active against HBV as well as HIV. Due to very low oral absorption, it is used as the disoproxil ester prodrug, which not only improves bioavailability but also intracellular passage of the active form. Tenofovir released from hydrolysis of the prodrug is dephosphorylated by cellular kinases into tenofovir diphosphate, which preferentially inhibits HBV DNA polymerase and HIV reverse transcriptase. Affinity for host DNA polymerase is very low. It also gets incorporated in the viral DNA to cause chain termination. Tenofovir disoproxil is incompletely but adequately absorbed after oral intake and is largely excreted by the kidney with a plasma T-half of 16 hours. It produces few side effects, which are mostly limited to the GI tract, nausea, flatulence, abdominal discomfort, loose motions and headache. Remarkably, renal toxicity is quite rare, though slight increase in serum creatinine occurs. Drug interactions are also not significant. 804. Section 12. Antimicrobial drugs. Administered in a dose of 300 mg daily, tenofovir disoproxil has produced good clinical and virological response in chronic hepatitis B. In a comparative study, higher percentage of patients responded within 1 year of use than with adifovir. A response rate of greater than 90% has been reported among HB antigen-negative patients. Tenofovir resistance has not developed during treatment of chronic hepatitis B, and it is effective in lamivudine-resistant cases. Due to its high efficacy, good tolerability, and low risk of resistance, tenofovir is being preferred for HBV infection, especially lamivudine-resistant cases. Tentide, 10 of 300 mg tab, 1 tab OD. Ribavirin, this purine nucleoside analog, has broad-spectrum antiviral activity, including that against influenza A and B, respiratory syncytial virus and many other DNA and double-stranded RNA viruses. Its mono and triphosphate derivatives generated intracellularly inhibit GTP and viral RNA synthesis and have other sites of action as well. Viral resistance to ribavirin is rare. Oral bioavailability of ribavirin is till 50%. It is partly metabolized and eliminated in a multi-exponential manner, accumulates in the body on daily dosing and persists months after discontinuation. Long-term T-half is 10 days. Administered orally or IV, ribavirin has been used in severe influenza A/B and measles in immunosuppressed patients as well as for herpes virus infections, acute hepatitis, but is not a first-line drug for any of these. The most common therapeutic use of oral ribavirin is in chronic hepatitis C. Though ribavirin monotherapy may produce a response, it is incomplete. As per current recommendation, the first-line treatment of chronic hepatitis C is oral ribavirin combined with injected peginterferon for 6 to 12 months. Recurrent cases are treated in the same way. Nebulized ribavirin is used for respiratory syncytial virus bronchiolitis in infants and children, particularly those with congenital heart disease, prematurity or other high-risk conditions. It has also shown efficacy in some rare viral infections. Dose 200 mg QID, 400 mg TDS for body weight greater than 75 kg, children 15 mg/kg day. Virazide, Ribavin 100, 200 mg caps, 50 mg per 5 ml SYR. Prominent toxic effects are anemia, bone marrow depression, hemolysis, CNS and GI. Symptoms. It is also teratogenic. The aerosol can cause irritation of mucosae and bronchospasm. Interferon alpha interferons, IFNs, are low molecular weight glycoprotein cytokines produced by host cells in response to viral infections, TNF, IL-1 and some other inducers. They have non-specific antiviral as well as other complex effects on immunity and cell proliferation. Interferons bind to specific cell surface receptors and affect viral replication at multiple steps, with viral penetration, synthesis of viral mRNA, assembly of viral particles and their release, but the most widespread effect is direct or indirect suppression of viral protein synthesis, i.e. inhibition of translation. Interferon receptors are JK-STAT tyrosine protein kinase receptors which on activation phosphorylate cellular proteins. These then migrate to the nucleus and induce transcription of interferon-induced proteins which exert antiviral effects. Interferons inhibit many RNA and DNA viruses, but they are host-specific. Those produced by another species have poor activity in man. 3 types of human IFNs, alpha, beta and gamma, are known to have antiviral activity. Only IFN2A and IFN2B produced by recombinant technology are available and are clinically used. Both are non-glycosylated low megawatt proteins administered by IM or SC injection. Their pegylated forms are meant for SC injection at weekly intervals. Plasma levels of PEGF2A are sustained twice longer than those of PEGF2B. After I.M.S.C injection, interferon is distributed to tissues. It is degraded mainly in liver and kidney and remains detectable in plasma for 24 hours. However, cellular effects are longer lasting because the interferon-induced proteins persist, so that IFN is generally administered thrice weekly. Complexed with polyethylene glycol, peginterferon, it is absorbed more slowly, exerts more sustained effects, permitting weekly administration and improving clinical efficacy. 805. Chapter 58. Antiviral drugs. Pegiafen has replaced IFN, except for consideration of cost. Alpharon, interferon alpha-2A 3 μ vial inch, Zabinex 3 μ, 5 μ vials for inch. Realpha-2B, Shanferon, Viraferin, interferon alpha-2B 3 μ, 5 μ vials for inch. Uses. 1. Chronic hepatitis B, IFN2 alpha 2.55 μu M2 or IFN2 beta 510 μu given 3 times per week for 4 to 6 months causes disappearance of HBV DNA from plasma and improvement in liver function tests histology in nearly half of the patients. High doses 10 μ, injected thrice weekly for 6 months, often produce prolonged remission, but relapses do occur. The PEGIFs 180 μg SC once weekly for 24-48 weeks produce better and more sustained responses. 2. Chronic hepatitis C. IFN-2 beta 3 μU 3 times weekly for 6 to 12 months has produced remission in 50-70% patients. Viral RNA becomes undetectable and liver function tests return to normal. Histology improves if response is sustained. However, relapses occur in majority of patients. PEGIFs 180 μg week are more effective and induce longer-lasting remissions. Combination with oral ribavirin increases number of responders and decreases chances of relapse. Combination therapy with IFN-pegifen plus ribavirin is particularly indicated in patients who do not respond to IFN alone. 3. AIDS-related Kaposi's sarcoma. IFN is used to treat AIDS-related Kaposi's sarcoma, but not to treat HIV as such. However, interferon accentuates hematological toxicity of zidovudine. 4. Condyloma acuminata, caused by papilloma virus, is usually treated with topical podophyllin. Intralesional interferon injection may be used in refractory cases. 5. H. simplex, H. zoster and CMV. For these infections in immunocompromised patients, interferon is inferior to acyclovir-ganciclovir. It may be used as second-line adjuvant drug. 6. Interferons are also used in chronic myeloid leukemia, follicular lymphoma, cutaneous T-cell lymphoma and multiple myeloma. Interferon is not effective orally. Clinical utility of SC or IM injected interferon is limited by substantial adverse effects. Adverse effects. Times flu-like symptoms, fatigue, aches and pains, malaise, fever, dizziness, anorexia, nausea, taste and visual disturbances develop few hours after each injection, but become milder later. Times neurotoxicity, numbness, neuropathy, altered behavior, mental depression, tremor, sleepiness, rarely convulsions. Times myelosuppression, dose-dependent neutropenia, thrombocytopenia. Times thyroid dysfunction, hypo as well as hyper. Times hypotension, transient arrhythmias, alopecia and liver dysfunction. Antiretrovirus drugs. These are drugs active against human immunodeficiency virus, HIV, which is a retrovirus. They are useful in prolonging and improving the quality of life and postponing complications of acquired immunodeficiency syndrome, AIDS, or AIDS-related complex, ARC, but do not cure the infection. The clinical efficacy of antiretrovirus drugs is monitored primarily by plasma HIV RNA assays and CD4 lymphocyte count carried out at regular intervals. HIV is a single-stranded RNA retrovirus which uniquely carries out reverse transcription of proviral DNA from viral RNA. Normally, RNA is transcribed from DNA with the help of a viral RNA-dependent DNA polymerase, reverse transcriptase. The primary cell type attacked by HIV is the CD4 plus helper T lymphocyte, but later macrophages and some other cell types may also be infected. When population of CD4 cells declines markedly, 200 cells MUL, cell-mediated immunity, CMI, is lost and opportunistic infections abound, to which the victim ultimately succumbs unless treated. Because the HIV genome integrates with the host DNA, eradication of the virus from the body of the victim appears impossible at present. Over the past 30 years, a number of virus-specific targets have been identified and drugs for these developed. We now have drugs which effectively suppress HIV replication and restore 806. Section 12. Antimicrobial drugs. CMI for variable periods of time. The two established targets for anti-HIV attack are A. HIV reverse transcriptase, which transcripts HIV RNA into proviral DNA. B. HIV protease, which cleaves the large virus-directed polyprotein into functional viral proteins. In addition, some newer targets being exploited are times fusion of viral envelope with plasma membrane of CD4 cells through which HIV RNA enters the cell, times chemokine coreceptor, CCR5, on host cells which provide anchorage for the surface proteins of the virus, times HIV integrase, viral enzyme which integrates the proviral DNA into host DNA. The first antiretrovirus, ARV, drug zidovudine was made available for use in 1987. Over the past 25 years, a large number of drugs belonging to three classes viz. Nucleoside or non-nucleoside reverse transcriptase inhibitors, NRTIs and NNRTIs, and HIV protease inhibitors, PIs, have been produced and extensively used. Recently, few drugs for the newer targets have also become available for use in patients who have failed several regimens employing the three major groups of drugs and have viral multiplication despite optimized background therapy. The aim of anti-HIV therapy is to cause maximal suppression of viral replication for the maximal period of time that is possible. For this, ARV drugs are always used in combination of at least 3 drugs, and regimens have to be changed over time due to development of resistance. Lifelong therapy is required. Over the past 35 years, HIV infection has emerged as a major global health problem. Though, with the use of effective antiretroviral therapy, ART, the prevalence is declining in the present century. WHO estimate in 2009 showed that 33.3 million people worldwide were living with HIV, and HIV/AIDS killed 1.8 million people in 2010, most of them in sub-Saharan Africa. India is a relatively low HIV prevalence country, but it has the third largest number of people living with HIV, which was 2.4 million in 2009, concentrated mostly among female sex workers, injection drug abusers, transgenders, etc. India launched its National AIDS Control Program, NAC, in 1992, but the prevalence and annual death rate has declined steadily only. After 2004, when the National AIDS Control Organization, NACO, rolled out free combination ART to eligible registered patients. Currently till 5 lakh patients are alive on ART asterisk, and new infections have declined by greater than 50% during the last decade, which in a large measure is due to effective use of combination ART. Nucleoside reverse transcriptase inhibitors, NRTIs. Zidovudine, it is a thymidine analog, azidothymidyne, AZT, the prototype NRTI. After phosphorylation in the host cell, zidovudine triphosphate selectively inhibits viral reverse transcriptase in preference to cellular DNA polymerase. Single-stranded viral RNA. Virus-directed reverse transcriptase, inhibited by zidovudine triphosphate, double-stranded proviral DNA. On the template of single-stranded RNA genome of HIV, a double-stranded DNA copy is produced by viral reverse transcriptase. This proviral DNA translocates to the nucleus and is integrated with chromosomal DNA of the host cell by viral integrase enzyme, which then starts transcribing viral genomic RNA as well as viral mRNA. Under the direction of viral mRNA, viral regulatory and structural proteins are produced in the form of a polyprotein. Finally, Viral particles are assembled and matured after fractionation of the polyprotein by viral protease. Zidovudine thus prevents infection of new cells by HIV, but has no effect on proviral DNA that has already integrated into the host chromosome. It is effective only against retroviruses. Zidovudine itself gets incorporated into the proviral DNA and terminates chain elongation. Resistance to AZT occurs by point mutations which alter reverse transcriptase enzyme. In the past, when AZT was used alone, greater than 50% patients became non-responsive to AZT within 1 to 2 years therapy due to growth of resistant mutants. Pharmacokinetics: the oral absorption of AZT is rapid, but bioavailability is still 65%. It is quickly. *NACO Annual Report 2011 to 2012, http www.naconline.org. 807. Chapter 58. Antiviral drugs. Cleared by hepatic glucuronidation, T1R 15-20% of the unchanged drug along with the metabolite is excreted in urine. Plasma protein binding is 30% and CSF level is tilde 50% of that in plasma. It crosses placenta and is found in milk. Dose: adults 300 mg BD, children 180 mg per square meter, max 200 mg, 6 to 8 hourly. Retrovir, Zidovir 100 mg cap, 300 mg tab, 50 mg per 5 ml SYR Virozid, Zidomax, Zydoin 100 mg cap, 300 mg tab. To be taken with plenty of water. Adverse effects: toxicity is mainly due to partial inhibition of cellular mitochondrial DNA polymerase gamma, which has higher affinity for zidovudine triphosphate than chromosomal DNA polymerase. Anemia and neutropenia are the most important and dose-related adverse effects. Nausea, anorexia, abdominal pain, headache, insomnia and myalgia are common at the start of therapy, but diminish later. Myopathy, pigmentation of nails, lactic acidosis, hepatomegaly, convulsions and encephalopathy are infrequent. Interactions: paracetamol increases AZT toxicity, probably by competing for glucuronidation. Azole antifungals also inhibit AZT metabolism. Other nephrotoxic and myelosuppressive drugs and probenecid enhance toxicity. Stavudine and zidovudine exhibit mutual antagonism by competing for the same activation pathway. Use: zidovudine is used in HIV-infected patients only in combination with at least 2 other ARV drugs. It is one of the 2 optional NRTIs used by NACO for its first-line triple drug ARV regimen. Its efficacy as monotherapy in AIDS was confirmed in the past. HIV RNA titer is reduced to undetectable levels and CD4 count increases progressively. Immune status is improved and opportunistic infections become less common. There is a sense of well-being and patients gain weight. AZT also reduces neurological manifestations of AIDS and new Kaposi's lesions do not appear. Mortality among AIDS patients is reduced. However, beneficial effects are limited from a few months to a couple of years, after which progressively non-responsiveness develops. AZT, along with 2 other ARV drugs, is the standard choice for post-exposure prophylaxis of HIV, as well as for mother-to-offspring transmission, CP 814-15. Didenosine, DDI. It is a purine nucleoside analog which after intracellular conversion to didenosine triphosphate competes with ATP for incorporation into viral DNA, inhibits HIV reverse transcriptase and terminates proviral DNA. Antiretroviral activity of didenosine is equivalent to AZT. Mutational resistance develops, but only few AZT-resistant mutants are non-responsive to didenosine also. Its use has declined due to higher toxicity than other NRTIs. Dose 400 mg per day for greater than 60 kg BW, 250 mg per day, less than 50 kg BW, 1 hour before or 2 hours after meals. Dynex EC, Dretro, Virosine DR 250 mg, 400 mg tabs. Oral absorption of didenosine is somewhat erratic due to acid lability. It is metabolized as well as excreted unchanged, t-half 1 to 1.5 hours. In contrast to AZT, it does not cause myelosuppression. The major dose-related toxicity is peripheral, Stocking and Glove, neuropathy, which may be irreversible, and rarely acute pancreatitis. Diarrhea, abdominal pain, dry mouth, and nausea are the side effects. Stavudine, D4T, it is also a thymidine analog which acts in the same way as AZT. By utilizing the same thymidine kinase for activation, AZT antagonizes the effect of stavudine, and the two should not be used together. It should also not be combined with didenosine, because both cause peripheral neuropathy. Resistance to stavudine develops as for other NRTIs. It is well absorbed orally and rapidly metabolized, t-half 1.5 hours. The anti-HIV efficacy of stavudine is comparable to AZT, and it is used in combination regimens. Frequent peripheral neuropathy, lipodystrophy, lactic acidosis, and rarely pancreatitis are the serious adverse effects which have restricted its use. However, for operational and cost considerations, stavudine is one of the optional components of first-line regimen used by NACO. Dose 30 mg BD irrespective of body weight, WHO and NACO Guidelines 2007, STAG, Stavir, Virostav 30, 40 mg caps. Lamivudine, 3-TC, this deoxycytidine analog is phosphorylated intracellularly and 808. Section 12. Antimicrobial drugs. Inhibits HIV reverse transcriptase as well as HBV DNA polymerase. Its incorporation into DNA results in chain termination. Most human DNA polymerase are not affected and systemic toxicity of 3-TC is low. Point mutation in HIV reverse transcriptase and HBV DNA polymerase gives rise to rapid lamivudine resistance. However, certain lamivudine-resistant mutants become slow-growing and have lower virulence. Some cross-resistance with didenosine has been noted among HIV. Oral bioavailability of 3-TC is high and plasma t-half longer, 6 to 8 hours. Intracellular t-half is still longer, greater than 12 hours. It is mainly excreted unchanged in urine. Lamivudine is used in combination with other anti-HIV drugs and appears to be as effective as AZT. It synergizes with most other NRTIs for HIV and is an essential component of all first-line triple-drug NACO regimens for AIDS. It is also a first-line drug for chronic hepatitis B. HBV DNA titer is markedly reduced and biochemical as well as histological indices of liver function improve. However, viral titers rise again after discontinuation. Even with continued medication, HBV viremia tends to return after 1 to 4 years due to emergence of resistant mutants. Dose for chronic hepatitis B, 100 mg OD for HIV infection, 150 mg BD or 300 mg OD. Lamivir 150 mg tab, 150 mg 5 ml Soln, Lamivir HBV 100 mg tab, Heptavir, Lamidac, Lamovit, Virolam 100, 150 mg tabs. Lamivudine is generally well tolerated and has low toxicity, because of which it is accorded high priority in use. Side effects are few: headache, fatigue, rashes, nausea, anorexia, abdominal pain. Pancreatitis and neuropathy are rare. Hematological toxicity does not occur. Abacavir, ABC. This guanosine analog is a clinically potent ARV drug that acts after intracellular conversion to carbovir triphosphate, which gets incorporated in proviral DNA and terminates chain elongation. Rapid reduction in plasma HIV RNA count and rapid rise in CD4 cell count has been noted when abacavir was given to AIDS patients. Resistance to ABC develops slowly, and it exhibits little cross-resistance with other NRTIs. Its oral bioavailability is 80% and it is mainly eliminated by metabolism. The plasma T-half is 1.5 R, but intracellular T-half of the active metabolite is 12 Rs. Hypersensitivity reactions such as rashes, fever, abdominal pain, bowel upset, flu-like respiratory and constitutional symptoms, which occur in 2–5% adult patients, are the major problems. Abacavir must be promptly stopped when the reaction occurs, because fatalities have occurred when patients developing the reaction were given further doses of ABC. A genetic basis and massive release of TNF have been related to this reaction. Abacavir should never be given again to a patient who has developed this reaction. Other side effects are not serious. Lipodystrophy is least likely. Avoidance of alcohol is advised. Combination regimens including abacavir are frequently used. Dose: 300 mg BD or 600 mg OD. Abavir, Abamune 300 mg tab. Tenofovir. This is the only nucleotide, not nucleoside, analog that is a relatively newer addition to the clinically used anti-HIV drugs. It is also active against HBV, and its pharmacology is described on P803. Tenofovir was initially used only in previously treated patients, but because of good tolerability profile, it is now being included in first-line regimens as well. Tenofovir-containing regimens have been found at least as effective and less toxic as other first-line regimens. NACO includes tenofovir in its first-line 3-drug regimen as an alternative when either zidovudine or nevirapine efavirenz cannot be used due to toxicity contraindication. Non-nucleoside reverse transcriptase inhibitors, NNRTIs. Nevirapine, NVP, and efavirenz, EFV. These are nucleoside-unrelated compounds which directly inhibit HIV reverse transcriptase without the need for intracellular phosphorylation. Their locus of action on the enzyme is also different, and they are non-competitive inhibitors. They are more potent than AZT on HIV-1, but do not inhibit HIV-2. Accordingly, they are not indicated in infections caused by HIV-2. If used alone, viral resistance to NNRTIs develops rapidly by 809. Chapter 58. Antiviral drugs. Point mutation of the enzyme, they should always be combined with 2 other effective drugs. Cross-resistance between NVP and EFV is common, but not with NRTIs or PIs. A patient failing any NRT regimen should not be treated with another NRT. NVP is well absorbed orally, is extensively metabolized, mainly by CYP3A4 and to a lesser extent by CYP2B6, with 80 of tilde 30 hours. Oral absorption of EFV is tilde 50%, but the T half is longer, 48 hours. It is completely metabolized, mainly by CYP2B6 and a smaller fraction by CYP3A4. Both are enzyme inducers and cause auto-induction of their own metabolism. However, EFV inhibits CYP3A4 as well. Nevirapine is started at a lower dose, 200 mg per day. The dose is doubled after 2 weeks when its blood levels go down due to autoinduction. Such dose escalation is not required for EFV. Rifampin induces NVP metabolism and makes it ineffective, but has little effect on EFV levels. If a patient being treated with NVP develops TB and is put on rifampin, NVP should be replaced by EFV. The NNRTIs are indicated in combination regimens for HIV. Either NVP or EFV is included in the first-line triple drug regimen used by NACO. These drugs have also succeeded in reducing HIV RNA levels when an earlier regimen, not including an-NRT, has failed. Nevirapine, NVP, dose, initially 200 mg per day, to be increased after 2 weeks to 200 mg twice daily, because autoinduction reduces levels. Nevimune, Nevivir, Nevipan, Neviritro 200 mg tab. Rashes are the commonest adverse effect, followed by nausea and headache. Occasionally skin reactions are severe. Fever and rise in transaminases occurs dose-dependently. NVP is potentially hepatotoxic. In patients developing NVP toxicity, it should be replaced by EFV, which has low hepatotoxicity. NVP should not be used in patients with hepatic dysfunction. Efavirenz, EFV, its side effects are headache, rashes, dizziness, insomnia and a variety of neuropsychiatric symptoms. However, these symptoms decrease over time and discontinue. Discontinuation rate, due to adverse effect, is low. EFV is contraindicated in pregnancy and in women likely to get pregnant, since it is teratogenic. Because of its longer plasma T half, occasional missed doses of EFV are less damaging. Dose, 600 mg OD on empty stomach. FR1, Viranj, Avirange 200 mg cap, 600 mg tab. Retroviral protease inhibitors, PIs. An aspartic protease enzyme encoded by HIV is involved in the production of structural proteins and enzymes, including reverse transcriptase and integrase, of the virus from the large viral polyprotein synthesized in the infected cell. The polyprotein is broken into various functional components by this protease enzyme. It acts at a late step in HIV replication, i.e. maturation of the new virus particles, when the RNA genome acquires the core proteins and enzymes. 6 protease inhibitors, Atjanvir, ATV, Indinavir, IDV, Nelfinavir, NFV, Saquinvir, SQV, Ritonavir, RTV, and Lopinavir, in combination with Ritonavir LPVR, have been marketed in India for use against HIV. They bind to the active site of protease molecule, interfere with its cleaving function, and are more effective viral inhibitors than AZT. Because they act at a late step of viral cycle, they are effective in both newly as well as chronically infected cells. Under their influence, HIV-infected cells produce immature, non-infectious viral progeny, hence prevent further rounds of infection. Oral bioavailability of PIs is variable, IDV and RTV tilde 65%, NFV greater than 20%, SQV 15%, and their plasma T-half ranges from 2 to 8 hours. All are extensively metabolized mainly by CYP3A4, except NFV, which is mainly a substrate of CYP to C19. All PIs, especially ritonavir and lopinavir, are potent inhibitors of CYP3A4, while some other CYP isoenzymes are induced. The PIs interact with many drugs. Nelfinavir, lopinavir and ritonavir induce their own metabolism. In the past, monotherapy with one of these drugs in previously AZT-treated patients reduced HIV viral levels, increased CD4 cell count and 810. Section 12. Antimicrobial drugs improved the clinical condition. However, viral resistance developed against the PIs over months due to selection of resistant mutants in a stepwise manner. Combination of NRTIs with PIs has been found more effective than either drug given alone, and triple therapy is more effective than double therapy. Current recommendations are to use a PI in combination with either 2 NRTIs or 1 NRTI plus 1 NRT. However, PIs are avoided in first-line regimens because their use in initial regimens markedly restricts second-line regimen options. Most guidelines, including that of NACO, reserve them for failure cases. Because different PIs inhibit as well as induce specific CYP isoenzymes to different extents, drug interactions with them are common and often unpredictable. Manufacturers' package inserts should be consulted while co-prescribing any other drug. Specifically, metabolism of PIs is induced by rifampin and other enzyme inducers, rendering them ineffective. Another problem in their use is the large tablet load. In case of different PIs, 6 to 18 tablets are to be taken daily, some on empty stomach, but others with meals, and this has to go on for months and years. Therefore, patient acceptability and compliance are often low. One of the strategies adopted to reduce the dose of ATV, IDV, LPV and SQV is to combine them with a low and subtherapeutic dose, 100 mg, of ritonavir. By reducing first-pass metabolism, ritonavir increases the bioavailability and by slowing systemic metabolism decreases clearance of the companion PI. This boosted PI regimen permits reduction in the number frequency of tablets to be taken each day. Lopinavir is marketed only in combination with ritonavir. Nelfinavir is not to be combined with ritonavir because it is metabolized mainly by CYP to C19 that is not inhibited. The most prominent adverse effects of PIs are gastrointestinal intolerance, asthenia, headache, dizziness, limb and facial tingling, numbness and rashes. Of particular concern are lipodystrophy, abdominal obesity, buffalo hump with wasting of limbs and face, dyslipidemia, raised triglycerides and cholesterol, which may necessitate hypolipidemic drugs, and insulin resistance. Diabetes may be exacerbated. Indinavir crystallizes in urine and increases risk of urinary calculi. Ajanvir, ATV, this PI is administered with light meal which improves absorption, while acid suppressant drugs decrease its absorption. ATV is primarily metabolized by CYP3A4, which is also moderately inhibited by it. Bioavailability and efficacy of ATV is improved by combining with RTV. The T-half is 6 to 8 hours. Dyslipidemia and other metabolic complications are minimal with ATV, but jaundice occurs in some patients without liver damage due to inhibition of hepatic glucuronil transferase. Dose: 300 mg OD with ritonavir 100 mg taken at meal time. Atazar 100, 150, 200, 300 mg caps. Indinavir, IDV, it is to be taken on empty stomach. GI intolerance is common. Excess fluids must be consumed to avoid nephrolithiasis. Hyperbilirubinemia occurs. It is less frequently used now. Dose 800 mg TDS, BD if taken with 100 mg RTV. Indivir, Virodin 400 mg cap. Nelfinavir, NFV, it is to be taken with meals, since food increases absorption, but bioavailability is erratic. NFV is mainly metabolized by CYP to C19. Often produces diarrhea and flatulence. Clinical efficacy may be somewhat lower than other PIs, less popular now. Dose 750 mg TDS, Nelfin, Nelvir, Navex 250 mg tab. Ritonavir, RTV, it is a potent PI, also a potent CYP3A4 inhibitor. Drug interactions, nausea, diarrhea, paresthesias, fatigue and lipid abnormalities are prominent. Though RTV, 600 mg twice daily, can be used as an antiretroviral drug, it is more commonly employed in a low dose, 100 mg BD, to boost other PIs like LPV, ATV, SQV, IND, but not NFV. Ritomune, Ritomax 100 mg cap, Ritovir 250 mg tab. Saquinvir, SQV, two types of formulations, hard gel and soft gel capsules, with differing but low oral bioavailability have been produced. The tablet load is large and side effects are. 811. Chapter 58. Antiviral drugs. Frequent photosensitivity can occur. Importantly, it is a weak inhibitor of CYP3A4. Dose 1200 mg TDS on full stomach, 1000 mg BD with RTV 100 mg. Sakin 200 mg tab. Lopinavir, it is available only in combination with RTV to improve bioavailability, though it is itself a CYP3A4 inhibitor. Diarrhea, abdominal pain, nausea and dyslipidemias are more common. Its dose needs to be increased by 1/3 RD if either NVP or EFB is used concurrently. Dose 400 mg with ritonavir 100 mg BD with food. Ritomaxel, Viletra, Lopinavir 133.3 mg plus ritonavir 33.3 mg cap. Entry, Fusion, inhibitor enfuvertide. This HIV-derived synthetic peptide acts by binding to HIV-1 envelope transmembrane glycoprotein, GP41, which is involved in fusion of viral and cellular membranes. Fusion of the two membranes is thus prevented and entry of the virus into the cell is blocked. It is not active against HIV-2. No cross-resistance with other classes of ARV drugs occurs. Administered SC twice daily, it is used as add-on drug to an optimized regimen in selected patients who have failed many earlier regimens and for whom there is no other treatment option. The injections are painful and cause local nodules cysts. The cost and inconvenience are prohibitive. CCR5 receptor inhibitor Maraviroc. The globular glycoprotein GP120 of the HIV envelope anchors to the CD4 site of host cell by binding to a cell membrane receptor, which mostly is the CCR5 chemokine receptor. Most HIV are CCR5 tropic. Maraviroc is a novel anti-HIV drug which targets the host cell CCR5 receptor and blocks it. Attachment of the virus and subsequent entry of viral genome into the cell is thus interfered. It has no effect on HIV strains that are CXCR4 receptor tropic. CXCR4 is an alternative chemokine receptor which also can bind GP120 or dual CCR5 CXCR4 tropic. Added to optimized background therapy in patients who have already been treated with several regimens and who have CCR5 tropic HIV infection, Maraviroc has resulted in marked reduction in HIV RNA load and improvement in CD4 count. It is active orally and there is no cross-resistance with any other ARV drug. However, CCR5 tropism must be proven before using it. Though a number of side effects are reported, tolerability in general is satisfactory. Since it blocks one of the human chemokine receptor, there is concern about impaired immune surveillance and increased risk of infection malignancy. Integrase inhibitor raltegravir. The HIV proviral DNA transcript in the cytoplasm of host cell translocates to the nucleus along with an integrase enzyme. The HIV integrase nicks host chromosomal DNA and integrates the proviral DNA with it. Raltegravir is an orally active drug that blocks this step by inhibiting the integrase enzyme. It is active against both HIV-1 and HIV-2. Because of its unique mechanism of action, there is no cross-resistance between it and any other ARV drug. Addition of raltegravir to optimized background therapy in repeatedly treated patients caused disappearance of HIV RNA from circulation in a higher percentage of cases and improved the CD4 cell count. It has also shown good efficacy in untreated patients as a component of initial triple drug regimen along with 2 NRTIs. Side effects are nonspecific. Myopathy is a potential toxicity. It is otherwise well tolerated. However, raltegravir is a new drug. Efficacy and safety need to be established. Some antiretroviral combinations. 1. Lamivudine 150 mg plus zidovudine 300 mg tab, 1 tab BD, Combivir, Cytocom, Duovir, Lamuzid tab. 2. Lamivudine 150 mg plus stavudine 30 mg or 40 mg tab, 1 tab BD, Lamivirus, Lamostad, Virolis tab. 3. Lamivudine 150 mg plus zidovudine 300 mg plus nevirapine 200 mg tab, 1 tab BD, Duovirin, Cytocomin, Nexiverzid. 4. Lamivudine 150 mg plus stavudine 30 mg or 40 mg plus nevirapine 200 mg tab, 1 tab BD, Lamostadine, Tromium, Virulence. 5. Lamivudine 150 mg plus zidovudine 300 mg to tab and efavirenz 600 mg 1 tab kit, Cytocomi kit. HIV treatment principles and guidelines. The treatment of HIV infection and its complications is complex, prolonged, needs expertise, strong motivation and commitment of the patient, resources and is expensive. Antiretroviral therapy, ART, is only 25 years old and is still evolving. Initially, anti-HIV drugs were used singly one after the other as each failed in a patient due to emergence of resistance. Understanding the biology of HIV infection and availability of several potent drugs belonging to different classes has mandated highly active antiretroviral therapy, HAART, with combination of 3 or more drugs whenever indicated. Monotherapy is contraindicated. It has been realized that even with HAART, which rapidly kills greater than 99% variants, a small number survive within the resting CD4 lymphocytes and invariably give rise to relapse when treatment is discontinued despite complete absence of detectable viremia and normal CD4 cell count for years. Relapses occur even if the same ART is continued after. Disappearance of viremia and immune reconstitution. This is because HIV reverse transcriptase is highly copying error prone. 812. Section 12. Antimicrobial drugs. Implying that viral replication produces changes at some base pairs and codons with high frequency, rate of mutation is high. Some mutations confer resistance to one or the other antiretroviral drugs. The resistant mutants are selected by anti-HIV therapy, and in time an apparently sensitive population is replaced by resistant variants. As the disease progresses in the individual, and several anti-HIV drugs are used, the HIV population becomes genetically complex and diverse with respect to susceptibility to drugs. Each failing regimen limits future treatment options. Even primary drug resistance, i.e. in untreated patients, is being detected in 5–20% HIV patients. In developed countries, drug resistance studies are being recommended before initiating ART. Since none of the currently available regimens can eradicate HIV from the body of the patient, the goal of therapy is to maximally and durably inhibit viral replication so that the patient can attain and maintain effective immune response towards potential microbial pathogens. Greater the suppression of viral replication, lesser is the chance of emergence of drug-resistant virus. Effective ART reduces infectivity of the patient for other persons, thus serves to limit transmission. Initiating antiretroviral therapy. Although it is attractive to treat all symptomatic and asymptomatic HIV-positive patients, little long-term clinical benefit has been demonstrated in asymptomatic cases with reasonable immune competence, CD4 cell count 350L. Arguments against early treatment in asymptomatic stable patients include times deleterious effect of anti-HIV drugs on quality of life, their side effects and toxicity, especially lipid abnormalities and drug interactions. Times risk of drug resistance limiting future treatment options. Times limited durability of available regimens. Times risk of dissemination of resistant virus. Times high cost. The best time to initiate anti-HIV therapy remains uncertain. Various professional bodies and health authorities have framed treatment guidelines from time to time. Highlights of the same are CD4 cell count is the major determinant of initiating therapy in asymptomatic cases. ART should be started before the immune system is precariously damaged and the patient becomes ill or develops opportunistic infection. Increased mortality occurs when treatment is begun after CD4 count has fallen below 200L and response to anti-HIV drugs is suboptimal. The U.S. Department of Health and Human Services Guidelines, 2010, recommend instituting ART to A. all symptomatic HIV disease patients. B. asymptomatic patients when the CD4 cell count falls to 350 μl or less. C. all HIV patients confected with HBV/HCV requiring treatment. D. all pregnant HIV-positive women. E. all patients with HIV nephropathy. In addition to above, the current NACO guidelines give priority in treatment to times all HIV-positive persons in WHO clinical stage 3 and 4. Times all persons who tested HIV positive 6 to 8 years ago. Times patients with history of pulmonary TB and or herpes zoster. times HIV-infected partners of AIDS patients, times all HIV-positive children 15 years of age. In developed countries, some authorities now recommend initiating ART in asymptomatic subjects at CD4 count 500 mul and not wait till it falls below 350 mul. Greater potency and better tolerability of newer anti-HIV drugs has prompted such recommendation in the hope of offering life expectancy approaching that of non-infected persons. Therapeutic regimens. Whenever treatment is instituted, it should be aggressive, hard, with at least 3 anti-HIV drugs. The optimum response to any regimen is reduction of plasma HIV RNA to undetectable levels, 50 copies mul, within 6 months. In treatment-naive patients, therapy with 3 drugs is considered optimal. Addition of a 4th drug affords no additional benefit, may be tried in failed patients only. Due to availability of multiple drugs, a variety of combination regimens are possible and have been employed. However, no specific combination can be considered optimal initial regimen for all patients. Choice has to be made on the basis of efficacy, durability, tolerability, convenience. 813. Chapter 58. Antiviral drugs. Drug interactions, impact on future options and cost. Taking into consideration the above factors and the experience gained so far, the first-line regimens universally include 2 NRTIs plus 1 NRT. In developed countries, placing emphasis on tolerability and efficacy over cost and other constraints, preferred NRTIs are lamivudine, abacavir, tenofovir and sometimes emtricitabine. Efavirenz is preferred over nevirapine as the NRT. However, NACO selects first-line regimens for untreated patients on the following principles. Times all regimens should have 2 NRTI plus 1 NRT. Times include lamivudine in all regimens. Times the other NRTI can be zidovudine or stavudine. Times choose 1 NRT from nevirapine or efavirenz. Times choose efavirenz in patients with hepatic dysfunction and in those concurrently receiving rifampin. Do not use efavirenz in pregnant women or in those likely to get pregnant. The first-line NACO recommended regimens are listed in the box. The other important general points are: times the 3 drugs in the regimen should belong to at least 2 different classes. Single class regimens are inferior. There is convincing evidence that 3 NRTI regimens are clinically less effective than those which include 2 NRTI plus 1 NRT. Times the 3 NRTI regimen is employed only when a NRT cannot be used. Times for treatment-naive patients, only PI-sparing regimens, 2 NRTI plus NRT, are chosen. They are more convenient with lower pill burden, simpler dosing schedules, more acceptable, better tolerated and produce less metabolic complications. Times the PI-containing regimens, 2 NRTI plus PI or NRTI plus NRT plus PI, are reserved for advanced CED cases who have failed earlier regimens. Times low-dose ritonavir-boosted PIs are preferred over higher-dose single PI due to lower pill burden and better tolerability. Times if drug toxicity develops, either the entire regimen should be interrupted or the offending drug should be changed. No dose reduction should be tried. Times drug holidays or structured treatment interruptions may briefly improve well-being by absence of side effects, but allow viral replication and increase risk of drug resistance, are not recommended. Times treatment is lifelong. Times institution of heart in patients with latent or partially treated opportunistic infection may produce immune reconstitution syndrome characterized by marked inflammatory reaction against residual organisms and constitutional symptoms due to re-establishment of immune function. Times pregnancy in women does not contraindicate ART. Drugs considered relatively safe during pregnancy are zidovudine, lamivudine, nevirapine, nelfinavir, saquinavir. Times the ARV drug combinations that should not be employed are given in the box on p814. Durability of the regimens depends mainly on adherence of the patient to it. Compliance is a major determinant of outcome. Use of combined drug formulations greatly improves convenience and adherence and are first-line antiretroviral regimens *. Preferred regimen 1. Lamivudine plus zidovudine plus nevirapine. Alternative regimens 1. Lamivudine plus zidovudine plus efavirenz 2. Lamivudine plus stavudine 1 plus efavirenz 3. Lamivudine plus stavudine plus nevirapine. Other options 1. Lamivudine plus tenofovir 2 plus nevirapine 2. Lamivudine plus tenofovir 2 plus efavirenz 3. Lamivudine 3 plus zidovudine plus tenofovir * recommended by NACO 1. Stavudine is substituted for zidovudine if patient is anemic 2. Tenofovir is included when there is toxicity or other contraindication to both zidovudine and stavudine 3. 3. NRTI regimen is only for patients unable to tolerate both nevirapine and efavirenz. 814. Section 12. Antimicrobial drugs. Recommended unless doses have to be individualized for specific reasons. Therapy should not be discontinued during an acute opportunistic infection, except in case of intolerance, interactions or toxicity. Since multiple antiretroviral, anti-P. gyrovesi, antitoxoplasma, anti-CMV herpes virus, antitubercular, antifungal or other drugs may have to be used in a patient, careful attention to drug interactions and toxicities has to be paid. Changing a failing regimen. An ART regimen is considered to have failed when times plasma HIV RNA count is not rendered undetectable, 50 copies μl, within 6 months therapy. Times repeated detection of virus in plasma after initial suppression to undetectable levels despite continuation of the drug regimen. Times clinical deterioration, fall in CD4 cell count, serious opportunistic infection while continuing drug therapy. Failure is due to development of resistance to one or more components of the regimen. Treatment failures are to be anticipated and occur invariably after 1 to few years. The failed regimen should be changed entirely, all 3 drugs changed, to drugs that have not been administered earlier. A single drug should not be changed or added to a failed regimen. In designing second-line regimens, drugs with known overlapping viral resistance should be avoided, e.g. indinavir should not be substituted for nelfinavir or saquinavir. Efavirenz should not be replaced by nevirapine. Viral resistance testing is recommended for selecting the salvage regimen. A boosted PI is nearly always included in second-line regimens. Because an NRT is nearly always used in first-line regimens and resistance to one. NRT means resistance to all NNRTIs. This class is practically out for second-line regimens. With repeated failures, it may become more difficult to construct an active combination. The integrase inhibitor, CCR5 inhibitor or fusion inhibitor may be considered at this stage. The second-line regimens suggested by NACO are listed in the box. Antiretroviral drug combinations to be avoided. 1. Zidovudine plus stavudine. Pharmacodynamic antagonism 2. Stavudine plus didenosine, increased toxicity, neuropathy, lactic acidosis 3. Lamivudine plus didenosine, clinically not additive. List of second-line regimens asterisk, in order of preference. NRTI components by component. Standard regimens 1. Tenofovir plus abacavir 1. Lopinavir R-pound 2. Didenosine plus abacavir 2. Atjanvir R3. Tenofovir plus zidovudine 3. Saquinvir R4. Tenofovir plus lamivudine 4. Indinavir R special circumstances 5. Nelfinavir 1. Didenosine plus zidovudine 2. Didenosine plus lamivudine asterisk suggested by NACO / low dose ritonavir boosted. Prophylaxis of HIV infection. Post-exposure prophylaxis, PEP, healthcare workers and others who get accidentally exposed to the risk of HIV infection by needle stick or other sharp injury or contact with blood biological fluid of HIV patients or blood transfusion should be considered for PEP. The aim of PEP is to suppress local viral replication prior to dissemination, so that the infection is aborted. However, PEP is not necessary when the contact is only with intact skin or with mucous membrane by only a few drops for short duration. It is also not indicated when the source is known to be HIV negative. The NACO recommends two types of regimens, see box, for PEP depending on the magnitude of risk of HIV transmission. In developed countries, where a large number of source HIV patients have received one or more anti-HIV regimens and may be harboring drug-resistant virus, alternative prophylactic regimens using stavudine, didenosine, abacavir, efavirenz have also been used. If the drugs received by the source person is known, prophy lactic regimen may be individualized to include at least 2 drugs that the source has not received. 815. Chapter 58. Antiviral drugs. There is no data to evaluate the value of prophylaxis after sexual exposure. The same regimen as for needle stick may be used. Perinatal HIV prophylaxis. HIV may be transmitted from the mother to the child either through the placenta or during delivery or by breastfeeding. The highest risk, to 3rd, of transmission is during the birth process. As per current recommendation, all HIV-positive women who are not on ART should be put on the standard 3-drug ART. This should be continued through delivery and into the postnatal period and has been shown to prevent vertical transmission of HIV to the neonate as well as benefit mother's own health. The first-line NACO regimen for pregnant women is zidovudine plus lamivudine plus nevirapine. However, women with CD4 count 250 cells mule face a higher risk of hepatotoxicity due to NVP and should be closely watched. EFV is teratogenic and not used, particularly in the first trimester. In HIV-positive women who are not taking ART, zidovudine, 300 mg BD, started during second trimester and continued through delivery to postnatal period, with treatment of the neonate for 6 weeks has been found to reduce mother-to-child transmission by 2-3rd. Combination therapy is even more effective. Even if not started earlier, AZT administered during labor and then to the infant is also substantially protective. Breastfeeding by HIV-positive mother is contraindicated because it carries substantial risk of transmission to the infant. Post-exposure prophylaxis of HIV. Basic to drug regimen for low risk asterisk. Zidovudine 300 mg plus twice daily lamivudine 150 mg for 4 weeks. Expanded 3-drug regimen for high risk $. Zidovudine 300 mg plus twice daily lamivudine 150 mg plus indinavir 800 mg thrice daily, or another pi, all for 4 weeks asterisk low risk times when the source is HIV positive but asymptomatic with low HIV RNA titer and high CD4 cell count. Times exposure is through mucous membrane or superficial scratch or through thin and solid needle. High risk times when the source is symptomatic AIDS patient with high HIV RNA titer or low CD4 count. Times exposure is through major splash or large area contact of longer duration with mucous membrane or abraded skin or through large bore hollow needle, deep puncture, visible patient's blood on the needle. Problem-directed study. 58.1 A dental surgeon consults you with the following problem. During a dental procedure, he got exposed to a 26-year-old female patient's blood and saliva through a piercing injury on the finger. A needle had penetrated across his gloves and skin to a depth of 2 to 3 mm, but was withdrawn immediately and the area washed under running water. On inquiry, the patient revealed that 1 year back she had tested HIV positive, but was asymptomatic and not taking any anti-HIV medication. A. Should the dental surgeon be advised to take post-exposure prophylactic medication for HIV, or no medication is indicated under the circumstances? B. If medication is advised, which drugs, doses and duration of use would be appropriate? See Appendix 1 for solution. Chapter 62 Anticancer drugs. Section 13.